Hello and welcome to our online version of childbirth classes. We have been so excited to add this to our options for education for childbirth classes, especially given the recent pandemic and our inability to hold these in person. It is our hope that the information here is just as valuable as in-person instruction. However, as this presentation cannot be interactive, please feel free to write down any questions as they come to you and discuss them with your provider at your upcoming appointment. Today's class will be focusing on the end of pregnancy and preparing for birth. This presentation has been purchased from Plumtree Baby and has been slightly modified for our use and especially for online instruction. First, I would like to introduce you to our four main physicians, any of which could be delivering your baby. There's myself, Dr. Fallon Mayab, Dr. Jennifer Nickel, and Dr. David Stroud that are all practicing at the Jolly Building across from the hospital. Dr. Nelson Perez sees his patients in Kennett and will be covering call at the hospital about 2 weekends a month. Our course topics today are outlined here below, beginning with pregnancy. A summary of pregnancy, most of this you might already know. First trimester is weeks 1 through 12, second trimester weeks 13 through 27, and third trimester weeks 28 to 42. With pregnancy anatomy, you'll notice the placenta in this picture is right here, up at the top of the uterus. This baby is head down. The cervix here is closed. The bladder lies right in front of that baby's head, which explains a lot of those sudden urges to use the bathroom. At the end of your pregnancy, there are lots of different things you can do to try to maintain your health, such as eating a balanced diet, continuing to take your prenatal vitamins, drinking plenty of water, some mild exercise, plenty of rest, and try to stay as stress-free as possible. For pregnancy exercise, in general, it is safe to continue any exercises that your body is used to prior to pregnancy. You can start some mild exercises such as walking, stretching, prenatal yoga, swimming at any point in your pregnancy, but avoid any high-impact exercise that your body is not used to. Getting ready for baby is not only a mental preparation, but your body also has many different changes as your labor begins. The hormones that you may be experiencing or may be causing some different feelings include estrogen, oxytocin, prostaglandins, and relaxin. Relaxin is very appropriately named, as its job is to relax the cartilage and different connections in your body to help spread your pelvis. They're not only responsible for allowing you to be able to deliver a baby, but also that classic waddle at the end of pregnancy. You may be feeling emotional and sensitive, crampy, increased vaginal discharge, loss of a mucus plug or any kind of mucus, bursts of energy, or softer, more frequent bowel movements due to all of these hormonal changes at work. The cervix begins to change before labor onsets as the baby's head is against it and as these hormones start to change it. You might be getting checked in the office starting out 36 to 37 weeks, and you'll be told the cervical dilation and effacement. This diagram demonstrates very well what these two numbers mean, with dilation showing how wide the cervical canal is, how many fingers can fit inside that cervical canal, and effacement shows how thin the cervix is, and you'll notice that it thins as it starts to dilate. Station is the third number, and it tells us how your baby is engaged in the pelvis, with minus numbers being higher in the pelvis and plus numbers being lower in the pelvis. Now moving on to labor and birth. So that big question is, when will labor begin? And if we knew the answer to that, everyone's life would be a whole lot easier. Most babies arrive sometime between 37 and 42 weeks, with your due date being at 40 weeks. But only 4 to 5% of babies are actually born on their due date. So when labor does begin, you have the first stage of labor, as well as the cervix dilates, the second stage of labor, which involves pushing and delivery of the baby, and the third stage of labor is the delivery of the placenta. Now, in the very beginning, the biggest question is this labor, is this not? Do I go to the hospital? Do I stay home? And it is very common to have contractions before you're actually in labor. And sometimes this early labor can last for hours or days, but you're not in labor just yet. Pre-labor contractions may be regular or irregular, but they often vary in frequency and length. They do not get closer, stronger, or longer, and they do tend to slow down or even stop if you rest, drink some water, soak in a tub, or any other kind of positional changes that could calm those muscles down. Labor contractions are regular and predictable. They steadily get closer, stronger, and longer, and they do not lessen with rest or drinking or any of the other interventions that can lessen pre-labor contractions. This next video is a really fun way to show the difference between these pre-labor contractions and labor contractions.
So first part is we need to get the ping pong ball in the balloon, and if you just put it in, if you just try and open it a little bit and put the ball in, it's going to get stuck. And as I always said in class, stuck is a word we don't like to have associated with childbirth. So what you have to do is get your fingers all the way to the very bottom of the balloon and crank it way open, and then poke the ball in, and then you have that. And I would usually have the class do that, stuff their own balloon. It was always fun, and we'd have a good joke about it. And so then we've got that ping pong ball in there, and we're going to inflate it about halfway. About like that. And then you can let that ping pong ball settle into the neck of the balloon. Sometimes giving the neck a little tug really helps. And then you can let go of it and it'll stay inflated. And I show people how if you just squeeze the side of the balloon like this, not much is happening to the neck of the balloon here, and it's not opening very much. These are the Braxton Hicks contractions that are just practice contractions that are more and more common towards the end of pregnancy, but they don't do all that much to what's happening to the cervix. So real contractions happen at the top of the uterus. That's where the power of contractions happens. It's the muscle fibers at the top here getting shorter and thicker, which squeeze the top and then pull up on the side of the uterus here. And just like with real contractions, I have everybody just squeeze and then let go, and then just squeeze and let go. You just have to do a little bit at a time. And you can see how we're getting that effacement or thinning of the cervix down here. And not much dilation is happening while we're still working on shortening the cervix here. And this is a lot of the work that's going on in early labor. It's mostly about that shortening and less about the dilation. So once we get to much more effaced, much more thin, then we're going to start dilating the cervix there. And a lot of people get kind of nervous at this point. It's like, oh no, I don't want to push. So we always have a bit of a joke. It's just like actual labor, where you'd be like, it's okay, just breathe, do it gently. You're stretching beautifully, and then just give it one more push, and the baby will be here. There you go.
So much like the video that we just played, contractions work because those muscle fibers squeeze baby down while they're pulling the cervix, and the long muscle fibers of the sides of the uterus up to help dilate and efface that cervix. How they feel is kind of hard to describe, and everyone describes them a little bit differently, but the one common thing is it's a tightening or cramping. As labor progresses, they feel more intense, and they can be all over your belly, wrap around to your back, deep into your pelvic floor. And in active labor, you'll feel each contraction build up and then peak and then slowly start to fade away. Contraction timing is the key to knowing, is this pre-labor or real labor. We measure these, and it looks very much like this on our typical monitoring strip at the hospital. And how we time them is the beginning of one contraction to the beginning of the next contraction, not the time in between the contractions. So you want them each to be about 5 minutes or less apart, and each contraction lasting a minute themselves. In the first stage of labor, as we mentioned before, this is as the cervix is dilating and effacing. It is split in itself in three different stages. There's early labor, which can last for quite a while. These are those pre-labor contractions that are really just kind of working at effacing your cervix and just kind of your body practicing. Active labor is when your cervix is actively dilating and effacing, and that varies from person to person, but can last anywhere from an hour to 8+ hours. Their contractions are every 3 to 5 minutes, lasting for over a minute. And in transition is that last centimeter or so, right at the end before pushing. The early labor is just as your cervix thins, and this says 6 centimeters, but it really varies on the situation when you might get admitted for active labor. In active labor, it's from complete effacement and 4 to 6 centimeters dilation all the way up to 8 centimeters and is a pretty intense point of labor. And in transition is to get that cervix fully dilated and the baby very well engaged, feeling lots of pressure and getting ready to push. In the second stage of labor, this is actively pushing the baby out, which we will demonstrate in the next few slides. The pressure builds up, baby moves down in the pelvis and sits very, very low. And the sensation is very much like needing to have a bowel movement. And it tends to peak at the peak of the contraction, but when you're really ready to push, that pressure is constant. It just gets worse at the peak of that contraction. The urge to push can be pretty overwhelming, and it can also be confusing because it really does feel very similar to needing to have a bowel movement. You can get hot, nauseated, dizzy. All these feelings are very, very normal. Pushing itself can take quite a while, especially for a first-time mom, and it always feels like it's 5 times longer than what it actually was. But everyone in the room is there to encourage you and teach you and train you the proper pushing techniques. There are different ways to push. There's spontaneous pushing, where you just listen to your body. When your body tells you to push and you feel that urge to push, you just do. And directed pushing, which is more common when an epidural is in place because you might not feel those sensations as strongly, then you have the nurses or the physician telling you when to push, when to start pushing, and counting you through that as well. Baby plays a very active role in manipulating and moving through the pelvis during the pushing and labor, which is demonstrated by drawings of the cardinal movements on this slide and with the video that follows.
The first step of your baby's journey probably took place before your labor even began. Engagement is when your baby's head settles into your pelvis and is sometimes called dropping or lightening. The next step is called descent, and it happens while you're contracting and pushing. The baby's head may move a little to the left or right, and her chin up or down, as she shifts until her head is in the right position to continue her downward descent. Once she's in the correct position, flexion begins. Your contractions and the bones of your pelvis put a small amount of pressure on your baby's head. This pressure pushes her chin into her chest. Her head gradually rotates towards your pelvic bone as her head descends deeper into your pelvis. This allows the back of your baby's head, the widest part, to pass through the widest part of your pelvis. The next step in your baby's monumental journey is called extension. As your contractions exert downward pressure and your pelvic muscles exert upward pressure, your baby's head changes position. Her head, which was curled forward against her chest, is now extended backward as if she's trying to look up at the sky. At this point, your baby's head emerges from your body. The next step, called external rotation, is when your baby turns her head to line it up with her shoulders. This is when you may possibly hear that first cry. The last amazing step in your delivery is called expulsion. The pressures caused by your contractions rotate your baby's shoulder under your pubic bone and upward. After the baby's shoulders come out, the rest of the body quickly follows, resulting in the birth of your beautiful baby.
After delivery, there's a third stage, which is delivery of the placenta. During this stage, you can be enjoying your first few moments with your baby on your chest while the physician takes over. There's some mild contractions to help the uterus shrink and to slow the bleeding. And usually the third stage is actively managed. The provider might give a fundal massage to promote detachment of the placenta with some gentle traction on the umbilical cord. We give additional Pitocin or just Pitocin if your body hasn't needed it yet at all to after the delivery of the placenta to encourage the uterus to maintain its tone and decrease the bleeding. Right after delivery, most of our providers are more likely to deliver the baby straight onto your chest for delayed cord clamping and immediate skin-to-skin contact. However, this is not the preference of every delivering mom, so this question will be asked of you in labor or right before delivery for your preference of direct skin-to-skin, or if you'd like the baby to go to the warmer for its first assessments and to get cleaned up and brought back over all swaddled and happy and warm. So that was a brief introduction to labor in general and how it works. Now we're going to move on to interventions that may happen or will happen in labor, and then how to develop your birth plan. So medical interventions are there to improve or maintain the health of the mom or baby or both. But we often try to ride that fine line of overused or unnecessary interventions and only use the ones that are evidence-based and will meet the goal of a happy, healthy mom and baby. If you ever have any concerns about an intervention, just speak up, ask questions. It is my hope that any intervention that is brought to you in labor, you are a full and active participant in making that decision for yourself. Electronic fetal monitoring is one of the basic interventions. We have two belts, one's on top, one's on bottom, traditionally. The one on top is called the TOCO, and it measures the pressure in your uterus. That tells us how often your contractions are happening. Then there's the fetal heart rate monitor that sits directly on baby's heart and traces baby's heartbeat throughout the labor. This can be continuous, like the entire time that you're there. It can be intermittent. We do have wireless options, so you're not just chained to the bed when we're monitoring during labor. You can be up walking around, sitting on a labor ball, multiple positions in labor. We do have internal monitors as well that can be used later in the labor process if necessary. And your physician should tell you about what we're using and why we're using it. IVs are necessary in our particular hospital. They don't always have to have IV fluids running, but the IV access is very important for medications that we may need to administer during labor to help you or baby or both. We always do baseline blood draws and the same lab tests on everybody, most of which are state mandated, including urine samples as well. We check the vitals throughout labor, and it varies on what stage of labor you're in and if your water is broken or not, how often those will be checked. Vaginal exams or cervical exams will be done on request or anytime the monitoring suggests we need to, or if we need to introduce another intervention. Sometimes it works out to about every 2 hours or maybe longer. The restrictions vary widely from provider to provider and in situational changes as well. So sometimes you will be allowed to walk around, sit on the yoga ball, change in positions. Sometimes it's more bed rest. It also depends on the situations, whether you're able to drink clear liquids, eat clear liquids, or if you have nothing by mouth at all. There are some variations in what we do from patient to patient. Sometimes labor doesn't follow that perfectly normal pattern and we need to intervene. And the more you understand this, the better prepared you can be to help make those decisions and not be surprised. So some unexpected situations may come up, and just always talk with your physician about it. What are the advantages? What are the alternatives? What are the drawbacks? We always are watching at the end of clinic and during labor for blood pressure rises or lowering. For amniotic fluid levels, if they seem to be too high or too low. We might do extra testing if you go past due date, or if we suspect that your baby is extra large, or if your labor is not following a predictable curve. There are some emergent situations as well. With very high blood pressures, and preeclampsia or eclampsia, if you have severe abdominal pain and very heavy vaginal bleeding, or when your water breaks and the umbilical cord delivers before the baby's head. These can all be signs of an impending emergency that we all need to act very quickly. Premature rupture of membranes is a little bit of a confusing term. It has nothing to do with how far along you are in your pregnancy. That would be preterm. So premature rupture of membranes purely is in reference to when your water breaks when you're not in labor, which happens about 1 out of 10 women. So then we call that PROM or PROM. And every provider kind of varies on how they handle that. Sometimes we watch for a little bit to see if your body picks up that signal that your water's broken and it's time to go into labor, or if your body does not respond to it and we need to augment your labor and get your contractions started with an intervention. So term, and we kind of talked about this at the very beginning with the due month from 37 to 42 weeks. That is split into 4 different categories. There's early term, which is 37 weeks to 38 and 6. Full term is 39 to 40 and 6. Late term is 41 to 41 and 6. And post term is 42 weeks and beyond. Anywhere in the range of 37 to 42 weeks is a normal length of pregnancy. Induction may be discussed as early as 38 weeks to plan for an induction at 39 weeks, or at any time when you have a medical necessity to be delivered earlier than that. That involves using different medications to start labor or ripen your cervix or get your body ready for labor before your body has its natural signal to do that. There are some medical conditions or signs in pregnancy that make us start with some fetal well-being tests, such as a non-stress test, which is being on the monitors, the same monitors that you are for labor, to see how your baby is doing in there, and biophysical profile, which adds some different markers on ultrasound in addition to that NST. So labor induction begins with checking the cervix to see how dilated, how effaced, what the consistency of your cervix is. Is it hard? Is it soft? To try to determine what is the best way to induce that cervix. This score is called a Bishop score, and that's not often reported to the patient by the physician. We just kind of tell you what your dilation and effacement is and what that means in terms of your delivery plan. The methods of induction can involve lots of different interventions. Sweeping the membranes can happen in clinic, and basically that involves the bag of water is very flimsily stuck to the inside walls of the uterus, and through a dilated cervix we can peel that away, and it releases your own body's prostaglandins and can push you over the edge into labor if your body's close to it already. In the hospital, we can use a Foley catheter, which has a balloon on the end, and that's kind of mechanical dilation, but it also gives constant pressure on the bag of water to give constant prostaglandins that can also ripen the cervix. We can break the water. We can use different man-made prostaglandins to ripen the cervix, and we can use Pitocin to give you those nice, regular, strong contractions. Alternatives to induction that you can do at home. This whole list has some great ideas and things that you've probably already heard of, but the only ones that are truly proven to work is orgasm and nipple stimulation. The others can certainly make you crampy, but might not really put you into labor. And nipple stimulation can be as easy as a warm, wet washcloth laid on the nipples while you're in a bathtub, or even using your breast pump as practice prior to delivery. That can work quite well as in addition. So the labor curve varies widely from person to person, and all of these curves you see on this slide are considered normal, just variations of normal. Sometimes everything goes very fast, and sometimes things go on a fairly normal curve but slower, and other times we have a period of a stall that then we can intervene and get you back on the curve. The length of pushing, or second stage, as we mentioned before, can take quite a while, especially for a first-time mom and especially with an epidural. So 2 to 3 hours is not abnormal. I can't say it's very common, but it's not abnormal. And then the best approach is patience, listening to your team to know that you're on the right track, and resting in between contractions as much as possible. Episiotomies are fairly rare these days. They are done still on occasion if it's really necessary for the health of your baby and to expedite the delivery. And it should never happen without you knowing it's about to happen and why. Forceps and vacuum are also called operative vaginal deliveries. That's when your baby needs to come out quickly, is very close to delivery, and can be an alternative to a cesarean. And once again, this should never happen without the physician telling you it is going to happen and why. Both are equally safe. Forceps are safer for baby and more likely to harm the mother, and vacuum is the opposite, but both are very safe if they're in the very trained hands. Meconium is baby's first stool, and it is like a green substance that makes the amniotic fluid green as well. We will often notice this at time of breaking the water or when the water breaks on its own, but sometimes it can develop as labor progresses. It can indicate fetal distress occasionally, but not always. So we use that in addition to the fetal monitoring to know if baby's in distress or not. It can change the outcome of the skin-to-skin and delayed cord clamping. If the baby comes out screaming immediately, everything is great, nothing changes on the plan. But if the baby comes out and needs a little bit of help with transition into life outside of mom, which can be common with or without meconium, then we quickly cut the cord so the nursery team can suction out any and all of that meconium-stained fluid prior to baby taking its first breath, and we'll get baby back to you as quick as possible. So variations in fetal positioning greatly impact the delivery of your baby. So vaginal deliveries occur with head down or vertex positions. And the optimal position is called an occiput anterior position, which is baby looking at the floor. That way the baby can execute those cardinal movements the best way and shorten your labor, both the first stage and the second stage. So a lot of times babies want to be OP or occiput posterior, and you may hear that term while you're in labor. That's when baby's looking at the ceiling, and those curves are still negotiable through labor, but are a lot more difficult to maneuver and can lengthen labor and lengthen pushing. We have lots of positioning in the bed while you're in labor to try to promote that baby to rotate around into the optimal position. Breech, which is butt or foot first, or transverse, which is sideways, are both positions that need to be delivered by cesarean. So with cesarean birth, sometimes you'll go into delivery knowing you're going to have a cesarean, and sometimes it is a not planned mode of delivery. But we will talk about it, so in the case that this happens, you're more prepared. So an overview of a C-section. A surgical incision is made on the lower abdomen. We call this a fan and steel or bikini cut. We prefer mom to be awake, so you can hear baby's first cry, see baby, and we will have local or regional anesthesia that numbs you from about the rib cage down so you don't feel what we're doing, so you can enjoy the experience. So whenever you go into labor and delivery knowing you're going to have a C-section, that tends to be because baby is breech or transverse. Your placenta is in a position that doesn't allow for vaginal delivery. There are some STDs that require a cesarean delivery. Multiples have a much higher risk of a cesarean delivery or any medical complications in baby or mother, or even a repeat if this is not your first. Unplanned C-sections can happen because the labor curve does not progress properly despite every intervention we can do to try to promote a vaginal delivery. It can happen because during pushing, you do happen to get to complete and start pushing and the baby doesn't want to descend or come down in the pelvis. It can happen during labor when baby shows us on the monitoring that it doesn't like the contractions and is in distress, or any other medical complications that make a C-section needed. So what to expect during the C-section. If it happens and is planned, you'll likely have a spinal, and that is a single shot of medicine that numbs you from the rib cage down. If it happens in the midst of labor and you already have an epidural, they can use additional medications in the epidural to achieve that same surgical level of anesthesia. You will have your IV and a Foley catheter to drain your bladder. Sterile drapes will be up so to protect you and to maintain the sterile field. You can have one support person with you, and we try to have baby on your chest as soon as possible after delivery. This slide says several hours in recovery, but that is quite outdated. You're back in your room recovering on the same floor that you were in labor in, likely in a different room that's not a labor room, and you'll be reunited with your baby about 30 minutes to maybe an hour after delivery. The next video is a very cute, fun, bloodless, yet fairly accurate representation of a cesarean delivery.
We're going to check to make sure that the anesthesia worked, so you could go ahead and just pinch the tummy, see if the patient felt it. Does the patient feel it? No. Nope. Okay, we're good to go. And we're going to start by making a transverse incision on the lower part of the belly. What do you see? Good job. So we went through the skin and the fat. Very good. This is the fibrous fascia. Now here's the rectus muscle. So we're just separating the muscles to the side. Okay, go ahead. Separate it to the side. So this is going to be our bladder blade. Keep it here to protect the bladder, which is under here. Here's the uterus. We're going to cut through the uterus. Yep. So that's the amniotic fluid, which is inside the amniotic sac. Do you see the baby? Do you think we can get him out?
Stick it really deep.
Oh my goodness. Okay. It's coming out.
Oh, help.
Okay, we have a head. Okay, all right.
Clamp.
So here's the baby. Congratulations. So
Baby's so cute.
Baby's so cute. We have to deliver the placenta next. There we go. There's the placenta.
So after your C-section, you'll recover in your room with very frequent vital signs and waiting on that spinal or epidural to wear off and start feeling your feet again. As soon as your feet and your legs are nice and awake and able to walk, it is a very good idea to get up and walk as quick as you can. You'll be eating some clear liquids until your bowels kind of wake back up and you pass gas again. Most of our C-sections have additional medications put in their regional anesthesia that provide excellent pain relief for 18 to 24 hours. So usually the additional medications used to manage pain are minimal and non-narcotic, so you don't have the additional sleepiness and nausea that you can get with narcotic pain medicine. The stay for a C-section is the same for a vaginal delivery. This slide says 3 to 5 days, and I can't edit that, but for us, people tend to go home on the second day post-delivery, whether it's a vaginal delivery or a C-section. So once you have a C-section, depending on the reason, it doesn't always mean you have a C-section for every delivery after that. So after delivery, it's important to discuss with your physician about your future with childbearing. It should not affect your ability to get pregnant or stay pregnant. There are certain kinds of C-sections that can be done that mean you cannot have a vaginal delivery again. That's called a classical C-section and increases the risk of uterine rupture way too much. So when you go into your following pregnancy, it's just a discussion to have with your physician about why did you have a C-section, how long ago was your C-section, and would you like to try to have a VBAC or not. The advantages, it is a quicker recovery. A C-section is major surgery, so if it can be avoided, of course that's best. Babies do well with any delivery, but they certainly have better breathing immediately after with the squeeze of the birth canal versus a C-section delivery. And breastfeeding rates tend to be higher, likely due to the recovery from surgery. We have mitigated that by getting babies and moms back together in recovery very quickly. The disadvantages with a VBAC attempt is you can still result in a C-section after trial of labor. A planned C-section has less risk than an unplanned C-section, and there is a small risk of uterine rupture that can be an emergent procedure and life-threatening to both mother and baby. So, birth preferences. After we've talked about all of these things with a basic overview of labor and delivery and the interventions that we may or may not need, it is important to kind of go through these options and develop some birth preferences or at least some questions about them to discuss with your provider. To set goals can be important and can also decrease your anxiety around the birthing process. You definitely want to think about where you give birth. If you are watching this video, your physician is likely one of the three of us at the Jolly Building or Dr. Perez and Kennett, and your delivery hospital will be Missouri Delta unless we need to send you somewhere else for different medical reasons. Who is with you? Right now, our visiting guidelines are one person during the COVID pandemic with hope to go back to our normal of 2 at some point in the future. You want to decide, do you want to be able to move freely and what positions you might like to try in labor, what medications and interventions are possible, and how you feel in the room as well. It is important to, when you think about these things, especially thinking about them at home and not in the presence of your provider, you might want to, before you write it down, think, is this negotiable or non-negotiable? Because your list of negotiables and non-negotiables might not match with your provider's list of negotiables and non-negotiables or with the hospital policies. So discussing them, knowing ahead of time where that discussion might go can be helpful. Whenever you're thinking about these birth preferences, you want to think about how can this positively affect your birth? How can this negatively affect your birth? And the whole picture. The overall goal of every provider in your room, whether it's the physician, the nurses, the techs, anesthesia, everyone's goal is a happy, healthy baby and mom. And we also want you to have a really good experience, but the outcome trumps the experience. So that is really important when thinking about your preferences as well. But we, again, certainly want a good experience for everyone and everyone to leave with their very happy and healthy with a wonderful baby. And it's also important not to think about these things right before delivery or bring them up at least right before delivery, so there's time to negotiate some of these things that are very important to you. Comfort measures are important as well. Support for labor is key. You want that one person that's with you to be supportive. It can be very hard to limit the people that are in your room, especially given the pandemic that you can only choose one. You don't want that one person to be someone that is known to cause you stress. You want that person to be in there that is supportive and can kind of anchor you in a way that helps you throughout your labor. You need to try to be in tune with yourself as well, knowing how do you react to stress and how can you typically calm yourself down and use those same methods in labor and childbirth as well. Relaxation can certainly help you get through those minute-long intense contractions. Try to relax your body as much as possible. Lots of breathing, massages, and positioning can all be very helpful as well. Mental relaxation, the more you are stressed and scared, the harder it is to relax your body physically and get through the intense part of your contractions. The fear surrounding childbirth, especially the first time, is it can be very intense, and different people cope with that in different ways. A lot of times you really need to analyze the fear to be able to alleviate that fear. You want to know what is so scary about it. What can you control? Discuss all your fears out in the open with your providers, as many appointments as you need to help you get through that fear. I think a lot of the fears surrounding a first-time birthing experience is a fear of the unknown. If you can't picture yourself in that situation, you have no idea what it's going to feel like, it can be very scary. And we've all been there. We completely get it. So a tour of the unit is extremely important with this, so you can at least picture the place you're going to be. And we are hoping to have a video tour of the unit in the near future as well. So comfort strategies are next. First one is breathing, which we touched on with relaxation. Slow, intentional breathing, especially during the contractions, can keep your body calm and get you through that as quickly as you not make it feel like it's a 5-minute contraction versus a 1-minute contraction. With medical options, we have IV pain medicines and we have epidurals. IV pain medicines, also called analgesics or narcotics, they are very relaxing. They're given through the IV. They're very quick acting. They're quick to act, and they're quick to go away. So they have minimal reaction on the baby. So we can give them up to about an hour before birth. So it'll be out of the baby system before birth too. So the baby won't be born kind of sleepy. They can cause a little bit of dizziness, but they can certainly relax you in a point of pretty intense pain. And then there's the epidural that's similar to when I described the spinal. It is medication put in the epidural space, which is right next to the CSF to numb this great area that you see there. That's like right above the uterus all the way down the legs. The spinal is a single shot that wears off after a few hours. The epidural is a catheter, a very small catheter threaded into that space that gives a continuous infusion of the medication, in addition to occasional boluses or extra doses of the medication when the pain starts to come back. So the epidural does not run out. There isn't a point there if you get it too early and then it won't work at the end. Once it's placed, it is constantly going through and constantly giving you pain relief. And while it takes away the pain of the contractions, it doesn't always take away the sensation of pressure. But the pressure sensation is paramount in helping you push effectively and decrease the second stage of labor. There are, of course, advantages and disadvantages of epidurals, which you can see on this slide here. While it provides very effective continuous pain relief, it does take away your mobility, and due to that decreased sensation of pressure, it can lengthen labor, especially the second stage. This concludes our first portion of our childbirth classes. And as I said at the very beginning, write down your questions. In pregnancy, the placenta steals all of your questions. So write them down, take them to your physician, and go over any questions that you may have from this. And soon we'll have the videos up for the second course, which is postpartum and newborn care, and then a video on breastfeeding as well. We are always open for feedback, so please feel free to use the comments below to help us improve to better suit your needs. Thank you.